Okay, hi everyone. Types of inflammation. So, types of inflammation scenario. Postpartum woman with pus coming out. So, coming out of the lentiferous duct. So, what's that? So, this is Staphylococcus aureus. Mind that. That's a separate inflammation. So, born of child with sepsis. So, on the top of the bone was a yellowish area and it was abscess. It's osteomyelitis. Also, this Staphylococcus aureus, because it's a yellow. That's why the name, which is a aureus, aura, which is yellow. Okay. If the kids have sickle cell, so this is salmonella. Why at the metaphysis of bone? Because most of blood supply goes here. Therefore, mechanism of spread is hematogenous. Therefore, come from another source, and then it gets into the bone. So, hot spread over face cellulitis due to staph, which is playoffs. Group A pathogens, called um, erysipelas, another name for cellulitis. Okay, talk about diphtheria, pseudomembrane, Corynetherium, diphtheria, gram-positive rod, that makes the exotoxin messing up ribosylation of the proteins via elongation factor 2. The toxin damages mucosa, submucosa, producing pseudomembrane when bacteria doesn't invade, produces a toxin, damages membrane. Clostridium difficile. So also does this. So it also produces a pseudomembrane and a toxin, which we measure in stool to make the diagnosis. Therefore, the answer is Clostridium difficile. So, pseudomembranous inflammation. Pseudomembranous, which is diphtheria, Corynebacterium diphtheria, this is a gram-positive rod. So that VPC pseudomembrane inflammation, so that's the diphtheria. Okay. So now this one, colon pseudomembranous colitis due to Clostridium difficile. Oh, this is pseudomembranous colitis, pseudomembranous inflammation. Okay. So talk about that. Pseudomembranous inflammation. Pseudomembrane, which is in diphtheria, but pseudomembranous, which is in the Clostridium difficile. Pseudomembrane like pseudomembrane pseudomembrane Clostridium difficile in colon. Now, fibrinous pericarditis, so usually with increased vessel permeability, seen in lupus, idiotropic syndrome, also seen in the first week of the myocardial infarction, and then again 6 weeks later in Dressler syndrome, seen Coxsackie, fibrinous pericarditis, usually with the increased vessel permeability seen in lupus, leading to friction drop. Also seen in the first week of the myocardial infarction, and then again 6 weeks later in Dressler syndrome, seen in Coxsackie. Okay, next one, heart fibrinous pericarditis. Oh man, like that, huh? It look like that. Okay, so just a little bit. Look better here. Okay. Uh, now talk about most common cause organism producing infection in third-degree burns. Pseudomonas aeruginosa, color of pus, green due to pyocyanin, green color. Third-degree burns, Pseudomonas aeruginosa, green due to pyocyanin. Basal cell layer on both sides of clot proliferate and go underneath it to clot. In the primary wound, it is usually sealed off in 48 hours. So appendectomy, key to wound healing is the presence of granulation tissue. So fibronectin is very important proteoglycan and is involved in the healing of the wound. So fibronectin is important adhesion agent and chemotaxis agent inviting fibroblasts. So in helping healing process. The granulation tissue starts at day 3 and is on its prime by day 5. If you ever pick at the scar and it split like mad, and you try to stop it, but it's still bleeding like mad, so that's granulation tissue. No granulation tissue means no healing of the wound. That's a collagen in initial stage of wound repair, which is type 3. Type 1, which is 1 is a bone. Type 2, which is cartilage. Type 3, which is something. Type 4, which is basement membrane. It is a type 3 collagen. Type 4 collagen is in the basement membrane. Type 1, which is in the very strong tensile strength in the bone, skin, tendon, ligament. So type 1, which is in bones, bone, skin, got strong tensile strength, which is for the type 1, which is collagen, bone, skin, tendon, ligament. After a few months, the collagen type 3 is broken down by collagenase, and the metallic enzyme converts type 3 into type 1. Zinc is a part of the metallic enzymes. This is why in a patient with zinc deficiency has a poor wound healing because it screws up the collagenase must replace type 3 with type 1. So max tensile strength after 3 months 80%. Most common cause of poor wound healing is infection. So Ehlers-Danlos defect in collagen due to synthesis or due to breakdown have a poor wound healing defect in collagen. Okay. So Marfan syndrome defect in fibrin. So erythrodermis, which is defect in collagen. Marfan defect in the fibrillin. Also have a poor wound healing. Patient with scurvy, this is vitamin C, right? Scurvy defect in hydroxylation of two amino acids, proline and lysine. So via ascorbic acid, which is vitamin C. Remember, it's a triple helix. So what makes a triple helix stick together and increase tensile strength is a cross bridges. When you cross bridge things, they anchor into areas where you have a hydroxylated proline and lysine. Therefore, have weak abnormal collagen in scurvy because there are no cross bridge to attach. So the cross bridge, which is due to proline and lysine, that's two amino acids. So therefore, the weak abnormal collagen in scurvy because no cross bridge to attach, leading to not being able to heal the wounds. Hemorrhage, hemothrosis. Collagen has a weak tensile strength because cannot cross bridge. So now granulation tissue with a lot of blood vessels due to lot of fibroblastic inflammatory cells from plasma cells and lymphocytes necessary for wound healing, rich vascular tissue, which is absolutely essential for normal wound healing. Keloid, which is hypertrophic scar. So this we call keloid. Excess in type 3 collagen deposition. So it causes a tumor looking lesion, especially in plaques, in the white keloid due to third-degree burn. So in another example, the chronically draining sinus tract of the skin, they tried to put antibiotics on it, didn't work. So there was an ulcerative lesion at the orifice of this chronically draining tract and nothing worked. What is it? It's a squamous cell carcinoma due to a lot of turnover. Type 3 converted to type 1 and fibroblasts are involved. A loss of cell division occurring which can predispose to mutation and cancer, especially squamous cell cancer. Squamous cancer is important because chronically draining sinus tracts and predisposes to squamous cell carcinoma. Hyperplasia predisposes to squamous cell carcinoma. But again, keloid, which is hypertrophic scar, accessing type 3 collagen, keloid, which is type 3 deposition, which causes tumor-looking lesions, especially in black people, in the white kid due to the third-degree burns. In another example, in a chronically draining sinus tract of the skin, they tried to put antibiotics on it, didn't work. There are an ulceration lesion at the orifice of this chronically draining tract, and nothing worked. What is it? The answer is squamous cell carcinoma. Due to a loss of turnover, type 3 converted to type 1, and fibroblasts are involved. Fibroblasts are involved. So a loss of cell division occurring which can predispose to mutations and cancer, especially squamous cell cancer. Squamous cancer is important because chronically drained sinus tracts and predisposed to squamous cell carcinoma. Hyperplasia predisposed to squamous cell carcinoma. Chronic inflammation. Talk about chronic inflammation. So, difference in immunoglobulin. So, acute inflammations, IgM is a main Ig immunoglobulin first, and then after that convert into IgG, immunoglobulin gamma, IgM, the main Ig shall need a loss of complement components in healing process. IgM is the most potent activator and have activation of complement pathway all the way up 1 to 9. IgM has a 10 activating sites, so pentamer. So IgG can activate the classical system. Okay. System IgM. As IgG can activate the classical system but does not go past C3 and stops and does not go on to C5 to C9. After 10 days, there is isotype switching and mu heavy chain is spliced out. Mu chain defines specificity of an Ig splices in the gamma heavy chain and IgG is made via isotype switching. So chronic inflammation which is IgG, acute inflammation which is IgM, right? For acute, but chronic which is IgG. So as a main Ig, so IgM will convert to IgG immediately. Difference in cell types. Acute inflammation which is neutrophil. Acute allergic reaction which is eosinophil. Mast cells are in tissue. Acute inflammation which is histamine and neutrophil. Acute allergic reaction which is a mast cell eosinophil. Viral infection which is a lymphocyte. Main inflammatory cell. Allergy, which is allergy, we see eosinophil. Acute inflammation, which we see neutrophil increase. For allergy, then we see eosinophil increase. And if with viral infection, if viral, then we see what? We saw lymphocyte. Lymphocyte is a main inflammatory cells. Talk about chronic inflammation, which is monocyte or macrophages. Important and see a loss of plasma cells and lymphocytes. Do not see pus as sedative. This is acute inflammation. Okay, increased vessel permeability and increased immigration of neutrophils into interstitial tissue. Protein-rich fluid with more than 3 grams per deciliter. So with a protein-rich fluid, we keep pus. Example, so cholecystitis. Now type 4 hypersensitivity reaction, which is a slow reaction. So granulomatous inflammation. Another example, granuloma, chronic inflammation, never acute. For example, cases, necrosis in someone with a TB, roundish pink multinucleated giant cells, granulomas, pathogenesis, type 4 hypersensitivity reaction, delay hypersensitivity. The main actors are cytotoxic T cells when they kill neoplastic, virally infected cells. So these are also type 4 hypersensitivity reaction. No antibodies involved. So poison ivy, which is type 4 hypersensitivity reaction. Back to tuberculosis invasion. Alveolar macrophages phagocytosis and there is hematogenous spread. Meanwhile, the macrophages is a T cell. Meanwhile, the macrophages is processing antigen. So then after which it presents active helper T cells. Therefore, the key players are type 4 hypersensitivity reaction or macrophages will process that antigen and presents antigen via class II MHC size to the helper T cells. These helper T cells release cytokines, gamma interferon, and macrophage inhibitory factor. Gamma interferon will activate the macrophage to kill the tuberculosis, Cryptococcus cytoplasmosis. Therefore, the gamma interferon is a trigger to active the macrophage. Macrophage cannot kill without the activation from gamma interferon because systemic fungi and tuberculosis have lipid in the cell wall. So this leads to caseous necrosis. All the pink staining cells are as so epithelial which activated macrophages have been activated by gamma interferon. When they die in style. So they fuse together and form multinucleated giant cells like a bare gravestone. Therefore, epithelial cells are fused macrophages. Black dots are helper T cells. There are two types of helper T cell. Subset 1 involved in type 4 delayed type hypersensitivity macrophages have interleukin 12. When it is secreted, the subset 1 helper T cells are presented with the antigen, then subset 1 become memory T cells. Interleukin 12 is involved in activating the memory subset 1 helper T cells. Most people in their primary disease usually recover with no problems, but the granulomas can calcify as seen on X-ray. So, a calcified granuloma is not dead because they are resistant to dying. So therefore, most cases of secondary tuberculosis are due to reactivation of TB. Okay, granulomas necrosis is due to reactivation. So positive PPD, PPD stands for purified protein derivative, ingested into the skin, the macrophage. The skin is a Langerhans cell, so histiocyte marker CD1, which have Welbeck granules look like tennis rackets on EM. They phagocytose the antigen, the PPD, and process it very quickly. They present it to helper subset 1, which has memory of previous exposure. So therefore, it hooks in the MHC class II antigen size as all immune cells do. And once the antigen PPD processed by the Langerhans cell is presented, the helper T cell releases the cytokines, producing inflammatory reaction within duration called is a positive PPD. So this is a picture of granulomatous inflammation. So Langerhans giant cells. Correlation. Older people usually don't host the very good type 4 hypersensitivity reaction. They have a less response to positive PPD, therefore have to do a double test on them. In patients with AIDS may not get any reaction. They don't have enough helper T cells, therefore don't have granuloma formation. Macrophage inhibitory factor kills some macrophages in that area. Therefore, with HIV, because helper T cell uh, decrease, so you don't form granulomas at all. Therefore, they will have a MAI all over the body with their granulomas because helper T cells are decreased. So when you do positive PPD, 5 millimeter in duration is enough to say it's positive. Okay, that's it for today, huh? Okay.